Okay, today I will talk about the polycystic ovarian syndrome. Okay, so the polycystic ovarian syndrome is the most common complex of endocrine disorder in the females in reproductive age. Okay, how we diagnose the polycystic ovarian syndromes? So based on American Society of Reproductive Medicines and ASHRI, they follow the modified Rotterdam criteria in 2003. So there is a three criteria, 2 out of 3. So first is a clinical or biochemical hyperandrogenisms. Any evidence of hyperandrogenisms, like hirsutism, hair follicles, hirsutism, like hair follicles in the male pattern, right? Or the testosterone level more than 2.5, up more than 2.5 nanomole per liter. If more than 5 nanomole per liter, we may suspect that and others cause of hyperandrogenism, like congenital adrenal hyperplasia, right? So that, and any examples, what examples? Number 2 is oligo or an ovulation of menstrual cycles. Okay. Right. Number 3, any PCO picture by ultrasound findings, which is include of more than or equal of 12 follicles, and then each follicles is diameter about 2 to 9 mm by the study, and the volume is about 10 millimeter. Okay, but I remember rule of 10. Rule of 10 means if 10 follicles, 10 millimeter diameter, and 10 millimeter volume, or rule of 8. We can use rule of 10, rule of 8. But in the original is a 12, 9, and a 10, right? Okay. What the issue behind it, there is a associated with the long term and short term complication, right? So in the clinical presentation, patient may present with the hyperandrogenism clinical by his hirsutisms. So we stage based on Ferriman Galway score, Galway systems, which they quantify the hair growth area. Okay, the hirsutism define if the Ferriman Galway score more than 8 or equal to 8, any acne or presence of irregular or an ovulation menstrual cycle or oligomenorrhea also. So patient may present like that lah. Okay, so and when we talk about the pathophysiology is uncertain or unknown. So the issue is insulin resistant, which lead to hypersecretion of LH, and then lead to hypersecretion of androgen hormone, because once the insulin resistance happen, there is a compensate with the hyperinsulinemia in blood. So at the same time, it increase the sexual hormone, it increase the sexual hormone binding globulin. It reduce the sexual hormone binding globulin, and then it increase the free androgen index and testosterone. So this testosterone lead to the immature or prevent ovulation, or immature the ovarian follicles. Okay, this is wrong. Okay, so in term of management, they associated with they associated based on the complication. Okay, right. So first is irregular menstrual cycles. So we may use a COCP to regulate the menstrual cycles. So number 2, in term of management, first line management, we must counsel the patient long term consequence of polycystic ovarian syndrome. Number 2 is exercise or weight control to reduce the weight. Okay, so we must bear in your mind, we reduce the weight, because by reduce the body weight, it will reduce the insulin resistance. Okay, the issue is insulin resistance, and improve the pregnancy outcome, improve the menstrual cycle. Okay, so by reducing the body weight is maybe women can going like Zumba or diet control. Okay, at this moment is it need the high motivation. Okay, I know this is very difficult to reduce the weight. Okay, in term of medication, it depend on, for first, like example, we want to treat the hirsutism, right? In hirsutism management in PCOS, they suggest first medication treatment. So in the medication treatment of PCOS, so they suggest we use the diet which contain of ethinyl estradiol about 35 microgram, and 2 milligram of cyprotron acetate about 2 milligram lah. Okay, another one is a yasmin which contain of drosperinone. It's a fourth generation of progesterone which contain of spironolactone. Okay, others is like topical eflornithine. Is effective. It's effective, but the side effect is thinning the skin, which requires sunblock later. Other like physical treatment, all is a hirsutism management. Physical management may benefit, for example, like electrolysis, waxing, bleaching, and laser. I refresh about the medical. The effect of the medical treatment like COC, like Yasmin or Lion, it take up to 6 to 9 months to act, by stop the hair growth, rate of hair growth. Okay. Okay, in term of menstrual problem, I already mentioned about the COCP when we may use. In term of infertility issue, patient, talk again about the reduce the body weight. That's important in the infertility management. So I optimize the health condition, because in the PCOS they are associated with diabetic, hypertension, hyperlipidemia, all the metabolic syndromes. Okay, and then we must started her on folic acid, especially an obese woman, because they are associated with the folate deficiency. Okay, at the same times, why we need reduce the body weight during the infertility management, because obese woman, it difficult to respond with the fertility treatment, especially during the ovulation induction. And then it difficult to we do the follicular tracking. Okay, and then it associated with the highly pregnancy outcome, and the pregnancy outcome, cumulative, the pregnancy rate is very low in the obese woman. Okay, so in term of medication, so in the PCOS woman, they are sensitive to with the induction of ovulation induction. Okay, we use the first line is we use as a clomid or clomiphene citrate. It's an anti-estrogen and estrogenic effects. We start during day 2 to day 5 of menses. We start with the 50 milligram initially, and increase if there is a no dominant follicle up to 150 milligram. 150 milligram. There is no benefit if we increase more than 150 milligram, for example like 200 or 250 milligram in term of ovulation induction. Okay, so once we start the clomid, we must do the follicular tracking, because it associated with ovarian hyperstimulation syndrome, and once they pregnant, they are associated with the multiple pregnancy. So follicular tracking is a obligatory, must do, right? to detect early of OHSS symptoms. Okay, so number one. Number two, and to look the any clomid response with the ovulation induction. Okay, by the definition of clomid resistant means after 150 milligram, three cycle of 150 milligram, still no dominant follicle, we define as a clomid resistant. And clomid failure is mean there is a dominant follicle but fail to conceive. Fail to conceive. Okay. Number two is a aromatase inhibitor, or known as a letrozole, which inhibit the aromatase enzyme by decrease the aromatization of androgen to estrogen. Means they inhibit androgen to estrogen, so it good in term of pregnancy outcome, show and lower incidence of multiple pregnancy and OHSS. But in UK they not recommended not lysine because of they say the recent study say it's associated with the high congenital malformation and high stillbirths, right? In case of clomid resistant, so there is a two option. Another, we use the gonadotropin regime, or laparoscopic ovarian drilling. Okay, in the laparoscopy, I will talk about laparoscopy ovarian drilling, about the surgical ovulation induction. So laparoscopic ovarian drilling, this is compared with the ovarian wedge resection previously. Okay, so in the laparoscopic ovarian drilling, the benefit is free from the multiple pregnancy or OHSS, but it required invasive procedure, and then also the benefit is not required any follicle tracking or monitoring. It's improved with the success rate is with the is recommended do by the full trained surgeon. The aim is to minimize number of determining point. So there's a rule of 4.4 second, 14 watt, and 4 mm the depths. Okay, that's a rule of 4. Okay, comparison between LOD and GnRH analogs. So they say the cumulative pregnancy rate is more better in the GnRH actually. And then LOD, about 50% of LOD laparoscopy already require the medication ovulation also after 6 months. Okay. Okay. Right. So I already taught the infertility, I already taught the esotism, I already taught the miscarriage in term of pregnancy. Okay, irregular menses. Once they pregnant, when the pregnant happens, so they associated with the gestational diabetic. So that's why metformin should be started. Metformin, the benefit of metformin in the PCOS woman, they improve the insulin sensitivity. Okay, so the study shows metformin increase the pregnancy rate, and then also increase the pregnancy rate actually. Okay, and then it must use combined with the clomid combination, because they compare with the metformin alone and combination with the clomid, the pregnancy rate improve with the combination with the clomid compare than metformin alone. At the same time, it help in reduce the body weight. Okay, the recommendation dose is 1,500 milligram to 2,500 milligram daily, up to 14 up to up to 12 week, 4 months, mean up to 3 months actually, to review the effects. So alright, so in term of pregnancy, the risk of gestational diabetic, and then some more is a preterm delivery, preeclampsia. Okay. About diabetic management, as diabetic management, hypertension, heart problem, or hyperlipidemia as a management of hypertension, right? Management of in due to according to the disease. What the risk of malignancy? So they are associated about 2 to 3 fold risk of endometrial hyperplasia. So that's why we required to induce or withdrawal bleed 3 to 4 monthly. So TVS, if we do the TVS, if ET less than 7 mm, is unlikely have endometrial hyperplasia. So but if more than 9 mm, this they say the sensitivity is 100% to predict endometrial hyperplasia. And so every 1 millimeter increment of ET, there is a 1.5 odd ratio to become endometrial hyperplasia. Okay, in case of patient have morbidly obesity and fail diet treatment or exercise, they recommended for bariatric surgery. Okay, that's all about the polycystic ovarian syndrome. Okay, thank you.